The worldwide data, friends, and Indian data, that's from my friend Dr. Rajiv Gupta from Jaipur. These data talk of poor control of blood pressure, poor management of blood pressure, tremendous inertia among the physicians to reach the target blood pressure, and inability to appreciate that the world itself is changing toward a stricter control to improve the prognosis of a patient with high blood pressure. The laxity with which the physicians are experiencing is very unexplainable. I did one study for one of the pharma industry to understand the efficacy of olmesartan with amlodipine and olmesartan with hydrochlorothiazide. Friends, over 3 months' time, none of the physicians, which was formidable, something like 22 physicians, they did not even bother to increase the dose of blood pressure medication, even though these patients have been seeing them for the last 12 weeks' time. The blood pressure was controlled to the target in just about something like, 40% of the individuals, despite the pressure from the PI, the pressure from the pharma industry to make sure that they are returning the, electronic records, suggesting that we have a lot to learn and a lot to learn from wiser people. I consider my good friend Dr. Sunil Kumar as a great friend and a great professional and one of the alter egos, because I have one more alter ego here in front of me, Dr. Prabhakar Koregol. I worked with Professor Sunil Kumar for almost about 10 years' time, and even after leaving JSS, we continue to publish very meaningful data which have been very useful to me for me to understand how the science is progressing. I wanted him to talk on what difficulties he's likely to face as a physician, keeping his shoes of professorship in his cabin, and he comes into the office and says that the blood pressure is not getting controlled. Would you like to believe that such a situation can exist in the universe? The trials which have been listed here, like ALLHAT, ASCOT, SPRINT, and STEP, and other trials, suggesting that when we listen to Dr. Sunil Kumar at the end of it, these challenges should be considered as opportunities to make sure that our patients get the benefit out of our expertise and the wisdom. With those remarks, may I request Dr. Sunil Kumar to get on with his presentation, please. The title of his talk is Safeguarding My Patient with Hypertension. Do I need some more data to initiate, to up-titrate and control blood pressure with drug therapy to reach the target blood pressure? Challenges. Yes. After ALLHAT, ASCOT, SPRINT and STEP and other trials. Professor Sunil Kumar, please.
So, dear friends, colleagues, respected chairpersons, at the outset I would like to thank Professor Dr. Nagaraj Desai for giving an opportunity to be a part of today's scientific program, and it's all his inspiration and the legacy that he has left in JSS that I am just following. So that means all the credit goes to him, some to me actually, that's all. So he asked me to speak on this particular topic, safeguarding my patient with hypertension. Do I need some more data to initiate, up-titrate and control the blood pressure with drug therapy to reach the target blood pressure? The challenges after ALLHAT, ASCOT, SPRINT, STEP and other trials. The title is so big and I was given 15 minutes. So I feel he should have given me some 5 or 6 more minutes for me. So I think I will do justice to this, sir, actually. So just to begin with my talk, so how do you safeguard your patient with hypertension? Point number 1, diagnosing hypertension. What is required to diagnose an hypertension? An accurate blood pressure measurement. Second one is you need to have a comprehensive cardiovascular risk assessment of the patient. addressing the therapeutic lifestyle changes. Then you move on to the pharmacotherapy. So you need to know when do you initiate the therapy, what are the first line of drugs that you want to choose, what is the role of combination therapy as a single pill combination, and the target blood pressure, intensive versus standard. Next is you have certain specific population subsets where you have to be very careful in choosing your drug and choosing the targets. And the last one is the patient support and the adherence strategies. So just before going into the topic proper, I want to tell one line about hypertension. What is very important in hypertension is how do you start the treatment. With what you start the treatment is not very important. How do you end at the end? So that means you need to have a clear-cut goals when you are going to start a pharmacotherapy in a patient with hypertension, and what is the target blood pressure that I need to achieve in my patient. So this is very, very important. So probably if you want to look at all these headings or the bullets that I am going to touch across, absolutely you are going to safeguard your patient with hypertension. So what is the harsh reality of the poor control? If you want to look at across from the NCD risk factor collaboration, only 23% of the women and 18% of the men with hypertension worldwide have their BPs under control, that is a target of 140/90. Look at this, 23% and 18%. Now what has happened is, as the guidelines have started evolved, more and more data has evolved, and these particular trial data has been incorporated into the guidelines. The cutoff levels, the target blood pressures being more stringent. In 2020, that is I am speaking about 5 years back, less than 25% of the adults with hypertension achieved the new targets of less than 130/80, and nearly 50% of the patients did not even achieve that older targets of 140/90. So now if you want to look at across the hypertension treatment cascade globally, nearly 50% of the patients do not know that they have hypertension. Most of the patients who know that they have a hypertension are not treated. Whomever are treated, a portion of them are not under control. And if you want to look at across, hardly around 20% of the patients who are diagnosed to have hypertension, who are treated adequately, have their BP goals to the target. It's hardly around 20%. This is the global data. But if you want to look at across our own data, the hypertension treatment cascade in India, the National Family Health Survey here, look at here, screening around 70%, around 34% are aware of hypertension, around 13% are on treatment, and 7.8% of the patients have their BP under goal. If you want to look at across these data, I'm going to tell you hypertension is the domain for everybody, starting from a general practitioner to a primary care physician to a broad specialist to all the super specialists. So you have a significant hypertension burden, everybody are aware of it, only 4 classes of drugs, simple mathematics to choose the medication, simple way of titration, still we are not in a position to achieve the BP goal. Look at here the blood pressure guidelines, how they have evolved over a period of time, starting from JNC to ESC to American Heart Association, the Canadian guidelines. Look at here, every year new trials are coming into the picture. They are incorporating guidelines, either they change in the definition, change in the targets for blood pressure, change in the way how you are going to do a risk assessment for these particular patients, and everywhere there is a confusion, and most of the patients' blood pressures are not under the goal. So I will just take you across through the journey of the trials, so wherein these are the certain landmark trials. So rather than giving about the detailed description about each trial, I'll just give you the way how it has been published in a timelines, right from the ALLHAT trial, which was published in JAMA to begin with, which was the largest randomized control trial comparing 4 medications, that is 4 antihypertensives: alpha blockers, ACE inhibitors, calcium channel blockers, and chlorthalidone. Doxazosinam, the alpha blocker, was prematurely terminated because of increased risk of cardiovascular events and heart failure. There was no difference in the primary outcome between ACE inhibitors, CCBs, and diuretics. Astonishingly, the diuretics were found to be much superior when compared to the other drug classes, especially in preventing the heart failure and stroke. Yes, the new leash of life was given to the diuretics, especially the thiazide type diuretic, the chlorthalidone, which was recommended as one of the drugs of choice that you can consider in the JNC guidelines. Yes, yes, we are all happy. Now, then came the ASCOT, which was published in Lancet 2005. The first calcium channel blocker and the RAS inhibitor was compared with the beta blocker and the diuretic. What was the outcome? Calcium channel blocker and the RAS inhibitor was superior to the beta blocker and the diuretic combination. Then came the on target. Yes, the era of ARBs. We know that telmisartan is a wonderful drug which was compared to an AC inhibitor ramipril. And what was the outcome? Telmisartan was non-inferior to ramipril. And again, there was a neutral outcome between both. And what was the outcome? Other outcome that was drawn was never combine an AC inhibitor and an ARB together. Then came the accomplished trial, which was published in NEJM 2008. The first AC inhibitor and the CCB combination, which was compared with AC inhibitor and diuretic. Look at here, AC inhibitor plus CCB combination was superior to the AC inhibitor plus a diuretic combination. Now, HIVET, elderly individuals, a combination of an AC inhibitor with indapamide was tested, and especially in elderly individuals, there was a significant reduction in the morbidity and mortality. Now, then came the ACCORD trial. So that means we know that yes, diuretics are good, AC inhibitors are good, calcium channels are good. So now what about the targets? So the ACCORD trial, the diabetic subset of patients, the blood pressure was intensely brought down. What was the outcome? So there was only a stroke benefit, but otherwise rest of the outcomes, it was neutral. So that means it was almost like a negative trial. Then came the SPRINT, which totally excluded the diabetic patients, and the intensive blood pressure group did fantastically well when compared to the standard blood pressure group. Then we are more bothered about the elderly individuals. Then came the STEP trial, which was published in NAGM 21. So wherein in patients aged 60 to 80 years, targeting the systolic blood pressure of 110 to 130 versus 130 to 150 was beneficial. Okay, then came the time. When do we administer the drugs? Whether giving it in the morning is better or giving it in the evening is better. So the time study gave us a clarity, no difference in the outcome whether you are going to use a drug either in the morning or in the evening, as long as there is a good 24-hour blood pressure control. Even that clarity we got. Then came the BP road trial. Yes, ACCORD trial, blood pressure in diabetic patients, negative outcome. But in the BP road, wherein diabetic patients and high-risk patients were enrolled, again the intensive blood pressure arm did much better than the standard blood pressure arm. Then came the SPRINT trial, high cardiovascular risk patients, irrespective of whether they had a diabetes or irrespective of whether they had stroke in the past, again an intensive blood pressure control group did much better than the standard blood pressure group. So that means if you're going to look at across the trials that has happened, yes, you know that drugs are effective, certain classes of drugs are effective, and irrespective of whether they are diabetic or high-risk patients, if you're going to do a very good or intensive blood pressure control, obviously you're going to get a good benefits. So what we can understand from this particular trial data is, very important, you need to bring down the blood pressure. You get all the benefits. The second, you choose an appropriate, which is a time-tested molecule, so that you are going to get an additional cardiovascular outcome benefit. So these are the two things that you need to do. So just to briefly tell you about the BP road trial, because here diabetic patients, aggressive control of blood pressure in the intensive arm, look at here with respect to the primary outcome, the hazard ratio was 0.79. And look at here the serious adverse events, the hazard ratio was 1. But except forget about the CKD progression, a small subset of patients who had an worsening of renal events. But overall, if you're going to look at across, the net clinical benefit was in the favor of an intense blood pressure control. Look at the SPRINT trial again here. The intensive blood pressure control group had 9.7% event rate, and in the control group it was 11.1%, and the hazard ratio was 0.88. Look at the serious adverse events. The hazard ratio was 3. The event rates, especially low blood pressure related events like syncope, very, very important, postural hypotension again, and worsening of the renal events actually. So if you're going to look at across the net clinical benefit again here, in the SPRINT trial, intense blood pressure lowering less than 130 was much favorable than the standard blood pressure group. Now, when there is a lot of confusion, what we do? We move to systematic review and meta-analysis. Look at here again. If you're going to reduce the blood pressure significantly in the intense blood pressure group and compare it to the standard group, especially in diabetes, in the systematic review and meta-analysis, obviously when you look at across, the intensive blood pressure group did much better than the standard blood pressure group. Again, if you're going to look at across the elderly individuals, more than 75 years, because we are always confused whether the blood pressure target is 130 or 140 or 150. Again, look at here, irrespective of the age, elderly individuals, targeting the BP to less than 130 again had a significant beneficial effects in terms of reduction of composite cardiovascular events, all-cause mortality, as well as the cardiovascular mortality. Look at across here, the serious adverse events, they were almost neutral. Hazard ratio was 1. So similarly, if you're going to look at across the systematic review and meta-analysis overall in the adult patients, and you're going to look at across the data that we have, there was a significant reduction in the cardiovascular events and cardiovascular death with the hazard ratios of 0.83 and 0.79, but it always comes with the cost of serious adverse events. So you need to balance the risk versus the benefit. Now, what is the ideal blood pressure that minimizes the cardiovascular and the end organ damage? If you want to look at across the guidelines from AHA 2017 to 23 ESH guidelines to ESC 2024, and now recently the ACC 2025 guidelines have been published. So now if you're going to look at it, there's a good confusion here. So if you're going to look at across to the 2025 guidelines of ACC that was recently published, there's a very good clarity about what are the initiation thresholds and what is the target blood pressure. It's very, very clear. If you want to look at across, the normal BP is less than 120 by 80. Systolic blood pressure between 120 to 129 and diastolic 80 is still not considered as hypertension actually, but it's considered as high normal blood pressure. And anything above 130 and diastolic above 180 is considered as hypertension. Anything between 130 to 189 and diastolic between 80 to 90 is stage 1 hypertension. So very clear, if you want to go for a primary prevention, patient is not at high risk, you are going to start the treatment for a low risk patient after 3 to 6 months of lifestyle intervention. If the blood pressure doesn't come under control, then initiate the pharmacotherapy. All high risk patients, you are going to start the treatment in stage 1 hypertension itself. I feel this ACC/HA guidelines of 2025 has shown a very good clarity about how do we approach. Now, whenever you want to assess the cardiovascular risk in a hypertensive patient, what do? We look at two things. A risk calculator you are going to use, or you are going to look at the target organ damage. Yes, a patient has got a stage 1 hypertension with a target organ damage. You straight away start the patient on pharmacotherapy without wasting any time for therapeutic lifestyle change. Or a patient who is going to have a high risk, that is a 10-year risk of having a cardiovascular disease of more than 7.5% or 10% based upon the score that you are going to use and the risk calculator, you are going to start the patient treatment as early as possible. So initially what do we use? To use the Framingham risk score. Then came the pooled cohort equation, and what is now that is recommended by our ACC/HA is the prevent score. Any individual who has got a 10-year risk of cardiovascular events of more than 7.5% has got a stage 1 hypertension, that's a systolic blood pressure more than 130, diastolic more than 80, straight away you can go ahead and start the pharmacotherapy. So to make the things more clearer, 4 major benefits groups which are benefited by starting the pharmacotherapy in stage 1 hypertension is, one is secondary prevention. A patient who has got an established atherosclerotic cardiovascular disease, systolic blood pressure above 130, diastolic above 80, please go ahead and start the pharmacotherapy. Presence of diabetes, presence of CKD, eGFR less than 60, and an estimated 10-year risk of cardiovascular disease more than 7.5% by the prevent score. So these are like what we have, the 4 major benefit groups for the statins. These are the 4 major benefit groups that we have for the blood pressure. Now, first line drugs, no confusion, thiazide type diuretic, long-acting dihydropyridine calcium channel blockers, ACE inhibitors, and ARBs. You use individual drug or any combination you want to use, but the ultimate goal is to get the BP to the target. So now combination therapy, preferably chosen is a single pill combination. Either you can use an ACE inhibitor or an ARB with a diuretic, or an ACE inhibitor or an ARB with CCB plus diuretic. That's a triple drug combination. So now we have gone more from a free pill combination to a combination therapy. That's a single pill combination. So what are the advantages? You can target multiple blood pressure pathways. It simplifies the treatment regimen, lowers the pill burden, reduces the clinical inertia and achieves the target blood pressures earlier, and there are fewer side effects because each drug can negate the side effect of the others. But the single pill combination sometimes do come with certain disadvantages like less flexibility and medication dosing and inability to isolate the adverse events if the patient develops any. So this is a meta-analysis which I want to tell you now, choosing a free pill combination versus a single pill combination. Look at here actually. Wonderful. So if you're going to use a single pill combination therapy, you have got a better adherence, better persistence, good systolic blood pressure reduction, good diastolic blood pressure reduction, and the patients achieving the target BPs is also very good. So what is the data you want to have? So if you want to use 2 drugs, you want to use 3 drugs, please go for a single pill combination. So now what are the ideal combinations that you can choose is, you can choose anything from ACE inhibitors or ARBs to CCBs plus diuretics. Whatever has been mentioned here, these are the time tested and proven combinations wherein you have got a good RCT data. So now lifestyle changes should never be disregarded or should never be given a least importance, because you know that approach of following a low salt diet, high potassium, regular exercises, quitting smoking, all these things are going to translate into a good BP reduction and translates to a cardiovascular risk benefits. This one study that I wanted to quote is the TRIUMPH study actually. This TRIUMPH study, patients who were diagnosed to have a resistant hypertension, when they were offered the lifestyle changes in a center-based lifestyle intervention versus a standardized education and physician advised group. Look at here the clinic BP. There was a significant reduction in the clinic systolic blood pressure, diastolic blood pressure, ambulatory systolic and diastolic blood pressure. That means this is one trial which will be quoted everywhere and anywhere. What is the significance of achieving a good lifestyle in a patient who is diagnosed to have hypertension? Now if you want to look at across, CKD is one of the major group which will be benefited by early treatment, especially when they have an EGFR less than 60. What are the ideal drugs to choose or to begin with is the RAS inhibitors. Now again, diabetes, any individual who has got a blood pressure of more than 130/80 as a diabetes is considered to be IHD equivalent, wherein definitely their prevent score will be more than 7.5% and start the treatment immediately. Now coming to the old frail patients, because now as our country is having more and more population actually, you are going to land up seeing more and more elderly individuals. So now do we have anything different for them? Look at across, any individual who is less than 85 years, no change in the BP targets. Please look at 130/80 for even less than 85 years old. And more than 85 years old with moderate to severe facility, the BP targets are 140/90. And very important, what are the drugs to be chosen? Let it be CCBs or RAS inhibitors, plus or minus low dose diuretics. Never use beta blockers until unless there is a compelling indication, and no to alpha blockers because they're more frail, more tendency for postural hypotension, more tendency to fall and develop fractures. Now, after knowing this actually, we have a good data, reduce the blood pressure, translates into good cardiovascular outcomes, and you choose right drugs, you again get a benefit. You bring down the blood pressure to the targets which has been proved as intense blood pressure group, and you know everything now actually. Now, what are the challenges for bridging this gap between the ambitious targets and the current state of hypertension control? So that means we need to have certain research and there are certain implementation needs. So what are they? Because we know the science, we know it works, but at the grassroots level, at the patient level, so we are not achieving it actually. So what is very important, you need to understand the barriers that prevent the patients from achieving the blood pressure goal. After the SPRINT STEP BP road trial data, there is a strong evidence for benefits of lower BP targets. Even in spite of that, we are not in a position to achieve the targets. And there is a clear need for research to identify the strategies to help to translate these guidelines into the everyday practice. And very important, what's the role of the digital health tools like remote blood pressure monitoring systems, mobile health apps, electronic health record integrated decision support tools, which is going to help in improving the adherence and outcomes. And very, very important, at the level of the clinicians, to take that barrier out from the clinicians, the clinical inertia we call it as, there's a greater clinical focus on lifestyle intervention, maximizing the benefits of the first line drugs as well as the single pill combinations. So probably whatever we have learned, whatever the data that we have got at present is adequate in terms of choosing your molecule, in choosing your time to initiate the therapy, in choosing your targets, but how do we translate this into the clinical benefits for the patients is the biggest barrier. So this can be overcome only by taking care of the patient-related barriers and the clinical inertia. So thank you for your patient listening.
Thank you, Dr. Sunil, for that wonderful presentation.
Thank you, sir.